Hello, my name is Kevin Harrington, and I'm a professor in biological cancer therapies at the Institute of Cancer Research and a consultant clinical oncologist at the Royal Marsden Hospital in London, UK. It's my huge pleasure to welcome you to this discussion of practical considerations when using immunotherapy to treat patients with head and neck squamous cell carcinoma. I'm here with Professor Barbara Burtness from the Yale Cancer Center in New Haven in the United States of America, and Professor Jean-Pascal Machiels from Clinique Universitaire Saint-Luc, Brussels, Belgium. So our agenda today will address a number of key themes. We will discuss immune checkpoint inhibitors in the treatment of recurrent and/or metastatic head and neck squamous cell carcinoma, with a view to understanding how do we apply the clinical trial data to everyday practice. We will look at factors that can be used to guide the use of immune checkpoint inhibitors in clinical practice and how we can identify and manage possible immune-related adverse events in patients with head and neck squamous cell carcinoma. We asked oncologists treating patients with this disease to submit questions for this discussion in advance. We had a great response, so thank you if you submitted a question. We've incorporated answers to as many of these questions as possible throughout the discussion. So I'd just like to rehearse with you briefly the licensed indications for immune checkpoint inhibitors to treat unresectable, recurrent and/or metastatic head and neck squamous cell carcinoma. If we consider pembrolizumab first, there are differences between the United States and Europe. In the first-line setting, pembrolizumab is approved as a combination therapy with platinum and 5-FU in all comers, irrespective of PDL1 CPS level. It is approved as a monotherapy where the tumor expresses PDL1 at a CPS greater than or equal to 1. In contrast, in Europe, it is approved as a monotherapy and in combination with platinum and 5-FU, where tumors express PDL1 with a CPS greater than or equal to 1, except in the United Kingdom, where it is only approved as a monotherapy, again with CPS greater than or equal to 1. For second-line therapy with pembrolizumab, in the United States, it's approved after progression on or after platinum-based chemotherapy. In Europe, there is a stipulation, again, for progression on or after platinum-based chemotherapy, but here the PDL1 has to be greater than 50% on a TPS value. When we consider nivolumab, this is approved in the second-line setting after progression on platinum-based therapy in both United States and in Europe. So I'm now going to turn to my colleagues, and I'd like to come to you, if I may, first of all, Barbara. How do you apply the clinical trial data for immune checkpoint inhibitors in the first-line setting?
Thanks, Kevin. Well, I think the first thing to do is to make sure that systemic therapy is the correct choice. So there are some patients with recurrent disease that is readily resectable or hasn't been radiated before. And there may be some patients, particularly those patients with HPV-associated disease who develop oligometastatic disease at a remove of several years from their original treatment, where SBRT or resection of a lung metastasis could buy the patient, a considerable period of disease control and maybe even in some cases cure. So I think the first thing to do is to make sure that systemic therapy is necessary and appropriate. But then if it is, I think there's no question that the addition of pembrolizumab, where the tumor is PDL1 expressing, enhances survival, whether it's a CPS of 1 to 19 or 20 or greater. And I think, I tend to think about the inclusion of chemotherapy in terms of the higher response rate and the higher complete response rate, and evaluate the patient's do they have long-term toxicity from a prior systemic therapy agent that they'd received? How are they likely to tolerate it, and how badly do they need that response? But I think if they're not resectable, if it's not oligometastatic disease that can be handled with SBRT, we're using pembrolizumab or pembrolizumab plus chemotherapy for essentially all PDL1 expressing patients.
Jean-Pascal, I'm imagining that you probably would agree broadly with much of what Barbara said. Maybe you could give your perspective.
Absolutely, we agree. So we all time present the patient to the multidisciplinary tumor board to discuss the case, to be sure that we cannot give another more appropriate treatment. And after, if CPS is positive, at least one, we go for pembro plus or minus chemotherapy, depending on the clinical situation.
Excellent. Now, I want you to imagine, maybe I'll come to you first, Jean-Pascal. When a patient achieves a complete remission on treatment, how long do you carry on therapy for? How long do you carry on with the IO therapy?
For a maximum of 2 years to complete the treatment. What we do also in this patient is we do a FDG PET to be sure that we don't have a small metastasis or a small local disease that we can try to ablate with some kind of radiation.
Barbara, do you always do that? Do you carry on for 2 years? Are there some patients where you may abbreviate the course of treatment?
Well, sometimes the course of treatment is abbreviated because of toxicity, and it's sort of interest to me that several of my long-term survivors attained CR after, in one case, even only a single dose of pembrolizumab, and remain disease-free. So I do think that complete response is we're only seeing it about 7 to 10% of the time, but it is a uniquely different form of response to immunotherapy, whether it's immunotherapy alone or immunotherapy plus chemotherapy. So yes, I continue for 2 years because that's how the study was done. I'm sort of aware of the data from lung and elsewhere that indicate that it's probably not necessary. I would love to see us have a compelling randomized study to demonstrate that. But I do have some patients who were who had to stop because of toxicity very early, and who have done quite well. And then the other thing I'll say is that when the pandemic hit, patients were understandably concerned about coming into the infusion room. And there were some people who were sort of in the second half of their second year and elected to stop, and they're all still doing well. So I think we don't know the answer, but I have tended to follow the experience of the study for now.
Very good, thank you. So we've dealt briefly with the first line setting, but of course we're aware that these drugs are also available and approved in the second line setting. How do you see the role of immune checkpoint inhibitors in the second line setting at the current time? And again, maybe I'll come back to you first of all, Barbara.
Well, we are tending not to use it as much for the PDL1 0 patients. And so the question is, how compelling is the evidence that they ought to be exposed to an IO agent at some point in their course? And I think that we saw from Keynote 012 that there were a small number of patients who were not PDL1 expressing who had responses. I'm fortunate to work at a center that has a very active early therapeutics unit. And so we tend to try to find a combination trial for those patients, whether it's with an HPV vaccine and a PD-1 agent or a co-stimulatory molecule of some kind, or in fact, a combination with an anti-angiogenic. But I am trying to make sure that all of my patients who didn't get it in the first line setting get it in the second line setting. If they are PDL1 low, I look sort of for something beyond monotherapy.
Excellent. And maybe I could ask you, Jean-Pascal, if you've had a patient who's had to discontinue immunotherapy in the first line setting because of significant toxicity and then subsequently relapses, would you use immunotherapy again in a second line setting?
That's a very good question. It depends on the kind of toxicity. If you have endocrine toxicity that you can substitute thereafter and that you are not putting the patient at risk, you may re-challenge. I am a little more reluctant if we had interstitial pneumonia or grade 4 liver toxicity. Well, in my practice, indeed, I never would challenge this patient at this stage because I'm afraid of the complication.
Very good, thank you. So just to round this section off, for patients who have persistent disease or whose disease grows back within 3 months of completion of chemoradiation, what do you do for those patients at the current time? Jean-Pascal, maybe I could ask you first.
Yeah, I think if we had several of these patients, and indeed some of them, when they have PDL1 expression, they respond to immunotherapy. So it will be indeed my first choice in this group of patients, because we know that challenging this patient with another chemo, they are probably not going to respond or very poorly. So yes, if I have a PDL1 expression on the tumor, I will go for immunotherapy.
And Barbara, indeed, these patients were allowed to take part, for instance, in the Checkmate 141 study. Do you use nivolumab for such patients, or do you stick with pembrolizumab?
Both nivolumab and pembrolizumab are approved for that indication in the United States. And since we've had access to the every 6-week pembrolizumab schedule, my patients have been tending to vote for that. Whereas when it was every 3 weeks, they were voting for nivolumab. So.
Yeah, and I can identify with that. I think it's more convenient for patients, isn't it? I'm now just going to take us on to a consideration really of factors that we can use when we're guiding ourselves in just trying to decide who we should treat with immunotherapy or indeed not with immunotherapy. And of course, we consider a number of factors really as part of our consideration, our global consideration of the patient. So we consider tumor factors, of course, the location of the tumor. Tumors that are in the oral cavity or oropharynx maybe have a different natural history to those in the larynx, hypopharynx. Obviously, we consider staging of the disease, both loco-regionally and in terms of the metastatic stage. So we'll consider both the T, the N, and also the M stage. We will consider whether or not patients have disease which could be considered platinum sensitive or indeed platinum resistant. And we need to consider the kinetics of the disease progression. So for patients in whom disease is progressing very rapidly, we may have a very different outlook to those whose disease is more indolent in its nature. And then, of course, we have to consider the nature of the patient themselves, their biological and their physical age, their performance status, the burden of symptoms that they experience, and the existing comorbidities with which they are dealing. And in particular, obviously, we think about cardiopulmonary and renal function, and also hepatic function before we embark upon treatment. We have to consider the psychological stress of the treatment and also the social status of the patient and their support network. And then again, of course, primarily, we have to think about the patient's personal preference, and we discuss these options with the patient. And a quote from a very nice review from Peter Sturz and Jan Vermorken states that with the exception of platinum sensitivity and resistance, the other treatment decision-making factors are continuous variables, and they should be considered conjointly while respecting patient autonomy and local resources. And I would endorse that comment. We're going to discuss some biomarkers, and of course, we're aware of current biomarkers, particularly PDL1, with CPS staining, less than 1 perhaps indicating not for use with immune checkpoint inhibition, greater than or equal to 1, yes, perhaps we will use immune checkpoint inhibition. We're going to discuss the relative roles of TPS versus CPS, and of course, there is an impact potentially of HPV status or P16 staining as a surrogate. We will discuss the potential role of tumor mutational burden. Microsatellite instability is uncommon in head and neck cancer, but is worth considering. And the role of circulating tumor cells and circulating tumor-free DNA must be considered, and an emerging role perhaps for the microbiota, both in the gut and in the oral cavity. And of course, these various biomarkers can contribute to our diagnosis, monitoring progression of disease, and response to treatment. And we're going to look at these in terms of them as potential tools for therapy guidance in the clinic. So I'd like to come back to the panel now, and I'd like to come to you first of all, Jean-Pascal, and just talk us through how do you use PDL1 testing, and how do you use the results to guide treatment, please?
So for all our patients with recurrent or metastatic disease, we try to have a fresh tumor biopsy, and we do PDL1, and we calculate the combined positive score. And we all know that higher is the score, better is the response, although we know that it's not completely predictive of the response. But yes, if the score is extremely high, it's increased my intention to give immunotherapy or to give pembrolizumab in first line. And when it's extremely high, it's also going to favor, but with also the other clinical factor, the fact that I will use it in monotherapy.
So Barbara, maybe I think we can all agree that PDL1 CPS is a key factor in choosing treatment, but what other factors do you utilize in your clinical practice to guide the use of immune checkpoint inhibitors? And maybe you could talk us through the decision around single agent therapy versus chemotherapy at this point.
Yeah. I think that's one of the great unknowns that came out of the first line trial. There are a couple of observations across the board. Chemotherapy had a higher objective response rate than pembrolizumab monotherapy. And we're all familiar with the head and neck cancer patient who really needs a response because of pain or airway complications, risk of bleeding, difficulty swallowing, maybe a mediastinal or hilar mass that threatens a post-obstructive pneumonia. And so I would say the thing that drives me the most towards chemotherapy is when I want a higher response rate. And then I think when you have a patient who's completely asymptomatic with a low metastatic burden, and as Jean-Pascal said, a high CPS, and you're a little bit more confident about what you're going to achieve with immunotherapy alone. And then, of course, taking into account your data on PFS2 being extended in people who've had first-line pembrolizumab monotherapy, you feel a little bit more comfortable about the monotherapy there. That said, the complete response rate is higher, and those low disease burden asymptomatic patients tend to be the HPV-associated cancers. And one of the sort of surprises in the forest plot from Keynote-048 was the great strength of the addition of pembrolizumab to chemotherapy in the P16 positive group, who, of course, are already extremely chemotherapy responsive. So I think that for a very fit patient who's potentially, very motivated to try to get to a CR, even if they're not so symptomatic, we have been incorporating chemotherapy. And I'm not sure it always needs to be a full 6 cycles. I'm not sure it always needs to be 5-FU, but I think that the response rates are higher with the combination.
Jean-Pascal, would you broadly agree with that, or do you tend to lean more towards single agent pembrolizumab therapy in this setting?
In my institution, we love to go with single agent when it's feasible, because indeed that's good for the quality of life of the patient, and sometimes we achieve a long-term partial response or stable disease with immunotherapy in monotherapy. But also, I want to stress that if the patient is symptomatic, is at risk, we will combine with chemo. But when it's possible, we go with pembro monotherapy. And I would say that 60% of my patients are treated in first intention with anti-PD1 in monotherapy.
Very nice. So I'd like to move now into discussing investigational biomarkers. But Barbara, do you use any of the things that I mentioned earlier? Do you use tumor mutational burden? Do you use things like the microbiota to factor into your discussions?
So we are not doing any determination on microbiota, and I'm not sure that I think we have prospective data in head and neck cancer that would allow me to interpret them. We do look at tumor mutation burden. I was quite impressed by the data from the EAGLE trial, the second line trial of durvalumab up against chemotherapy, which first of all showed that for the high TMB patients, the performance of chemotherapy in the standard of care arm was extraordinarily poor. And second of all, showed that in this trial, which had broadly been negative, that there was a striking benefit in those with a TMB of above, I think, 16 per megabase. So that's something that's reported on a Foundation Medicine genome profile that we can get here. And so if I have a patient who's got low PDL1 but a high TMB, I would think about immunotherapy there. And then the one time I had somebody with a microsatellite unstable cancer, that patient also did spectacularly well with immunotherapy. I think the other thing that we've all been very intrigued with, right, is the nanostring RNA reflection of interferon response gene transcription. That's not clinically available to me, but I think is pretty intriguing.
Jean-Pascal, do you use anything in addition, any other biomarkers routinely in use?
Not routinely. I think that I don't have access to routine TMB, although it's interesting. It's also quite controversial. We have some data that show that sometimes it's not completely predictive. I also personally think that PDL1 expression, TMB, interferon gamma signature, T cells infiltration, they all indeed reflect the same biological process, that you have already a T cell response and that you need to be able to block the break that you have to the immune response. But I don't use other biomarker than PDL1.
So I'm guessing that neither of you is taken with the notion of using, for instance, the NLR, the neutrophil to lymphocyte ratio, as a measure of likelihood of response. That's a very brief answer from each of you. So we'll move on now to the next session. I'd like us now to just think about immune-related adverse events. And so we've had a lot of questions in advance of this discussion from the audience were around safety. And so this is clearly a critical topic for us to discuss. And of course, it's fair to say that immune-related toxicities can affect any part of the body, as I say to my patients, from the top of their head to the tips of their toes. And you can see listed on the slide that's an adjunct to this discussion, some of the common tissues that are affected. And these can be, of course, relatively mild toxicities that are a nuisance to the patient but don't affect their health. Ranging on the right-hand side of the slide, you can see listed some of the more severe, indeed life-threatening and potentially fatal toxicities, which we all fear and we all manage as actively as we can to avoid them causing a detriment to our patients. So Jean-Pascal, maybe I can ask you, what procedures would you put in place to monitor for immune-related adverse events, both during treatment and also following treatment? Because of course we have to remember that patients can develop immune-related adverse events even after cessation of therapy.
But first we try to involve the patient. So we discuss with them, we explain them the benefit, the risk, what they should be careful about. We have also the chance to have a study nurse that will help the patient throughout the treatment. And after he can meet this nurse, and again they can re-explain everything. So I think it's really important to draw the attention of the patient. Okay, that's great drug. Side effects are generally manageable, but sometimes it can be life-threatening. And we explain that, for example, if you have dyspnea, if you have diarrhea, if you don't feel well, please call us and come. And after at the medical level, each time that we are going to infuse anti-PD1, they have a complete blood test with liver enzyme. They also meet the doctor with a complete physical examination. And I think it's extremely important that we don't do this just by phone or by not being very careful, because for the few percentage of patients, we will have a life-threatening complication that we need to find quite rapidly.
And again, Barbara, I'm guessing that you would agree with nearly everything that Jean-Pascal has said. Are there any additional things that you put in place, and maybe you could broaden your answer to then begin to deal with how you manage the common immune-related adverse events in your practice, please?
Yeah, so I agree 100% with what he said. I think maybe the two additional things I might tease out, the rate of hypothyroidism has been quite high in patients treated with immunotherapy for head and neck cancer. And of course, many of these patients are at risk for iatrogenic hypothyroidism from their prior radiation. So we do monitor the TSH probably insanely often, but every time they come. And then the other thing is that when we are doing chest imaging, I think that sometimes that interstitial pneumonitis can present really just as a few ground glass opacities. The patient's not symptomatic, and we would call that grade 1. We would see that patient as able to continue on their PD-1 inhibitor, but we probably would put some oxygen monitoring, so O2 saturation at rest and with ambulation before every dose if we were aware that the scan had been showing grade 1 pneumonitis, and we'd probably be getting that scan a little bit more often if it was somebody who had underlying chronic obstructive lung disease or had some radiation injury to the lung previously, or for any other reason we thought was higher risk. We'd probably get pulmonary involved kind of early. But I think that, the very broad guidelines of grade 1, you just monitor very closely. And it's with grade 2 and 3 when you start holding drug and instituting steroids. I think, very similar to the other diseases.
And in terms of patients on long-term steroid medication, what measures do you put in place there? Do you get the specialist advice of your local endocrinology service? Do you do bone protection measures relatively early on in patients who are a little older? Can you just maybe give us a flavor of some of the things that you do there to support your patients? Maybe Jean-Pascal first, I could come to you.
Yeah, but as I already said, we saw this patient at the beginning quite frequently, and we ask advice from endocrinologists. We have endocrine things that we think we cannot manage, or also we have the chance to have access to dermatologists. They like to be specialized in that area. I think we should also emphasize that we should not jump on the steroids too rapidly. So if we have a grade 1, we should try to do something with topical steroids if it's a cutaneous area. We should try to substitute if we have a thyroid dysfunction, so to avoid to lose in efficacy.
Very nice. Barbara, maybe I could just ask you as well. There has been discussion, some concerns about two things that I think we see in head and neck cancer patients as well that we've discussed in the past. An increased risk of bleeding, perhaps, and also some of the facial edema that we see on treatment. Could you give us your perspectives around those, please?
Yeah. Well, so the bleeding is something that I think in the head and neck cancer field has come up with targeted therapies before. So the early gefitinib trials, for example, had increased risk of bleeding. But several of the head and neck randomized trials had brief holds put on them because there was a question of increased risk of hemorrhage. These are extremely rare events. However, and I think it's still perhaps a little unclear how certain we are that they're increased, but there have been cases that have been observed, and as I mentioned, 2 trials put on hold. So if we have a patient with a neck recurrence that is abutting a vessel, or a patient has had even the slightest bit of streaking of blood in their sputum or anything, we do tell them that there is a risk, and that this is something where rapid intervention can make a big difference. And so if they cough up a couple tablespoons of blood, we want them to call and to be in our emergency department as soon as possible. And we have a group of interventional neuroradiologists who handle the angiograms and the placement of the coil very expertly. So we think haven't had to need to do that too often, but we do want the patients to be aware. And then for the facial edema, particularly the patients who had trimodality therapy for their definitive treatment, I think we see facial swelling, neck swelling that's out of proportion to what the patient might have seen before they went on the PD-1 inhibitor. And my own observation is that tends to fluctuate, so it's often going to get a little bit better on its own. We talk to the patients about lymphedema management and elevation of the head, and make sure they're not living on salt. And in general, really try to avoid high-dose steroids to manage that. And I think it's quite uncommon that we really need to get to that length.
That's excellent. Thank you. And again, I'm guessing, Jean-Pascal, you'd agree with those comments, but I'd like just a very brief answer. Do you do any particular tests? Are you aware of any particular tests that can predict a risk of adverse events? Because I certainly am not.
I'm not either, yeah.
Yeah, I think that they would be very beneficial. I know a number of groups are trying to work out algorithms whereby we can predict toxicity. So I think the last point I'd like to come to is when you've got a patient who has to stop immunotherapy because of an immune-related adverse event, maybe Jean-Pascal, give us your perspective. Do you switch them immediately to cytotoxic chemotherapy to maintain pressure on the tumor, or do you do something different?
I try to do something different, except if I'm obliged because the patient has a rapid progression. But no, I try to manage the immune adverse event with steroids, to taper the steroids, and to do the tumor stratification when needs to be done. And if the patient is in stable disease or sometimes has a response, I will certainly not jump on the chemo. Yeah.
And
only
I'm
if I'm
guessing,
obliged.
Barbara, just a very brief answer, similar response from you?
Absolutely. I mean, some of these patients you can observe and you'll continue to see the response improve even though they're not on anything. So we don't rush to chemo.
Absolutely. Thank you both. So I'm afraid we've run out of time. I mean, I think we could have gone on for a good deal longer with our discussions. Really interesting perspectives on the use of immunotherapy in both the first line and in the second line. Clearly, we focus mostly on the first line setting, but I think a lot of very interesting perspectives on the use of either single agent immunotherapy, combinations with cytotoxic chemotherapy, discussions around how to manage immune-related adverse events, and how to make sure that we can continue to treat our patients for maximum gain with the lowest risk of adverse events. So I thank you both, Barbara and Jean-Pascal, for these really interesting discussions. I'm very happy to have had the opportunity to chair this meeting, and I thank the audience for tuning in, and I hope you found something here of interest in our discussions. Many thanks.
Thank you.
Thank you, Kevin.